Thank you all for the opportunity to present our work. Here are our disclosures. As we're all familiar, surgical training largely relies on traditional measures of intelligence and success. The bulk of our residency and fellowship training experience is dedicated to the management of patient care, surgical judgment, and technical performance as a whole. There's a general lack of non-technical professional development in training and in continuing medical education for practicing surgeons. More recently, there's been an evolving appreciation of the importance of emotional intelligence in the practice of medicine. This shift toward enhanced collaboration and teamwork requires a shift in surgical training and our practice paradigm. The new emphasis on leadership skill development means we need to provide non-technical training for our trainees and for our practicing surgeons. Prior study has linked operative technique with patient outcomes as judged by peer surgeons, but no study has demonstrated a link from surgeon personality traits, leadership styles, self-awareness, and ability to collaborate with surgeon performance and patient outcomes. In this context, we sought to determine if an individual surgeon's leadership style and non-technical skill profile could be correlated with their patient-level outcomes after bariatric surgery. We use data from the Michigan Bariatric Surgery Collaborative. The MBSC is a statewide collaborative sponsored by Blue Cross Blue Shield of Michigan through the Value Partnership Program. This collaborative enables peer surgeons to get together to identify and implement best practices, learn from their own patient care data, and learn from peer bariatric surgeons. This reaches approximately 40 hospitals throughout the state and more than 70 bariatric surgeons. In order to assess surgeon leadership skills and style, we use the Lifestyle Inventory tool. This is a self-development and coaching tool that's served as a metric of leadership and non-technical skills for practicing surgeons in our study. The LSI measures 12 individual styles of thinking and behavior. These range from humanistic and encouraging to avoidant, oppositional, and power styles. These 12 styles can then be collapsed into 3 major clusters. The first is constructive, second is passive defensive, and the third is aggressive defensive, with the idea that they would represent an overall different thinking and behavioral style. Each person participating in this study had 12 individual scores that were then reported out to them as these individual metrics that were based on percentiles. We had 35 participating surgeons throughout the MBSC take this assessment in October of 2014 under the direction of an executive coach. Each individual received their report and follow-up to help them with improving their leadership skills. But what we sought to do was to connect this to their patient-level outcomes. So using prospective patient data as collected by the MBSC, we calculated risk-adjusted rates of postoperative complications from bariatric surgeons throughout our state. We adjusted for patient age, comorbidity, and the specific bariatric procedure they had. We then stratified surgeons into quintiles of their performance in each of these 12 domains, and then again in our 3 major clusters. From 2006 to 2017, the 35 bariatric surgeons in our group performed over 43,000 bariatric procedures. This included 17,000 Roux-en-Y gastric bypasses and almost 22,000 sleeve gastrectomies. Each surgeon who participated had between either 43 and 4,300 procedures collected by the MBSC, with an average of right around 1,200 procedures in our database. These procedures taken together had a risk-adjusted rate of any adverse event after surgery of 14.5%. When we look at our clusters, the aggressive cluster, which is the stereotypical one we think all surgeons would be really excellent at, actually contains some of our lowest scores. So we found that for the power score, the individual domain, our surgeons had a score around 36.1 on average, with a median of 25. This was actually the lowest of any of the 12 domains that was measured by this tool. In the aggressive cluster taken together, the average score was about 41.7, but ranged anywhere from 6 to 95. When we look at our passive cluster, again, something stereotypically we didn't think that the surgeons would have high scores for. The passive score is about 52.4 on average, but again, had a huge range of 14 to 94. We saw this wide variation in all of the 4 styles that collapsed together to the passive style. Similarly, when we look at a constructive style, we saw significant variation with an average right around 50, but ranged between 13 and 97. So when we then went to look at the impact of these styles on the rates of adverse events, we looked at aggressive first. We didn't see any difference between surgeons who had high aggressive scores and low aggressive scores in terms of their overall rates of adverse events after surgery. But when we looked at our constructive style, we found that surgeons who had a high rate of constructive style had a much lower rate of risk-adjusted adverse events after surgery, suggesting that surgeons who excelled in those domains might have a lower rate overall. A similar pattern was seen in surgeons who had high scores in passive domains. They also had a low rate of adverse events after surgery that was statistically significant. 14.8% for those in the highest score domain and 18.7% in those in the lowest. We admit that there are some limitations to this study. We thought it was really interesting data that we don't often have for practicing surgeons that we can then compare to their prospective patient outcomes. This was limited to about 35 bariatric surgeons throughout our state, so the ability to extrapolate is limited, but it's an interesting starting point. We're also unable to assess how they had any non-technical skill training before this. Had they been participating in leadership training, executive coaching, anything to improve their non-technical skills? And we're so far unable to measure growth or changes in their non-technical skill domains. We have, however, repeated the LSI study, and we hope to link with surgeons to see if they've been improving over time. So in conclusion, we found that surgeons have tremendously diverse leadership, thinking, and behavior styles. There are significant potential impact of this on the delivery of care to our patients. So we therefore think that it's essential to cultivate surgeon non-technical skills to improve the delivery of patient care, specifically intentional self-improvement, development of interpersonal skills, and receptiveness to feedback. Thank you, and I'll take any questions.